Hi everyone, I am Dr. Thomas Mathew from St. John's Medical College, Bangalore. It's a great pleasure to be invited to deliver this talk in the fifth Paktrims, and I am very grateful to Dr. Mohammad Wase and Naib Ali Khan to invite me to deliver this talk. And today's talk is on neurofasciins and multiple sclerosis. And all of you know what is serendipity. It's the occurrence and developments of events by chance in a beneficial way. And my talk on neurofasciins and MS also was some serendipitous discovery which happened over the course of last 3 years. And you know that many of the discoveries in the field of medicine, like aquaporins, were discovered by Peter Agre and was working on the Arch blood group antigen. Then he found an unexpectedly different 28 kilodactyl protein that they could not explain. They thought it's an artifact, but later it was found to be the aquaporin channels, and it was in 1990s. And after that, the aquaporins were discovered, and then you discovered the aquaporin antibodies, and then we identified the NMO spectrum disorder, and it changed the field of practice in MS and other demyelinating disorders. In a similar way, we know that we have now more antibodies, and now are there something else in MS? Are there further subtypes of MS? And these are the questions which we may see over the further presentation. This is Dr. Kadilkar who had invited me to deliver a talk on rituximab in neuromuscular disorders, and I'm grateful for him because while preparing that talk on rituximab, I came across this neurofasciins, and then we did further studies on MS and neurofasciins. And this is Dr. Sudhiran. He's one of my colleagues who was trained in Mayo Clinic. He's a neuroimmunologist. He has an immunology lab in Kochi, Amrita, and his lab helped us in working on this neurofasciin. So I'm grateful to both of them. And you know this entity called autoimmune nodopathy or paranodopathy. It is characterized by central and peripheral demyelination, hypertrophic spinal roots. Trigeminal and oculomotor nerves can be involved in autoimmune nodopathy, and they are poorly responsive to intravenous immunoglobulin and corticosteroids, but good response to rituximab because they are Ig4 antibody. And you know that the Ig4 antibody does not fix complements, and they're super sensitive to rituximab. And you have the musk myasthenia, which melts away with rituximab. So similarly, we have the IgG4 subtype of autoimmune neuropathy, which responds to rituximab. This is a case of a 43-year-old woman with no medical history, coming with a 3-year history of progressive hand and feet paresthesias with mild postural and headal tremor. This MRI, which shows multiple small plaques suggestive of multiple sclerosis, both in the brain and in the spinal cord, in the periventricular regions. But further investigation showed thickened roots of the brachial plexus roots. We can see that the cervical roots are thickened, and then there is a conduction block. So this is a case of combined central and peripheral demyelination. Here the CSF-OCB was positive. And then this is from the published article where it's an anti-neurofascin 155 causing central and peripheral demyelination. This is another one of our cases, an young man who had seen in 2015 October with right index finger tingling and hand weakness. We investigated. He had conduction block in the right ulnar and right median nerves with reduced conduction velocity. And then we had other nerves also showing the conduction blocks and reduced velocity. And then we had the median and ulnar showing sensory involvement. And then if latencies were prolonged, and a CSF showed increase in proteins with for lymphocytes. And so he was diagnosed as Lewis-Sumner syndrome, a variant of CIDP. And he had few relapses over the 6 years and all responded to steroid. And in 2021, he came with binocular diplopia, which was pupil sparing, and MRI brain was normal and was suggestive again third no policy. And then he also complained of a Lermit symptom, for which we did an MRI of the spine, which showed a plaque in the cervical region, and you can see the plaque here. And he also case of combined central and peripheral demyelination with Lewis Seminor and spinal cord involvement. And here anti-neurofascin 155 was positive, and I started him in rituximab, and is doing extremely well with rituximab pulses, which is going every 6 months, and is 500 milligram every 6 months, and is doing well. And meanwhile, I was preparing the talk for Kadilkar. We found this article on anti-neurofascin antibodies associated with white matter disease, central nervous system, a red flag or a red herring by Gupta et al. And here we can see that there were around 7 cases. And one of the cases, you can see a 55-year-old lady coming with dragging of the left foot for 2 years, Lehermit's phenomenon, insidious onset progressive, MRI shows multiple lesions. So clinically more like a PPMS, and but her anti-NF140 IgG in the serum is positive. And here the nerve conduction studies are normal. There is no peripheral demyelination. And this led to, because there were reports of neurofascin causing isolated central demyelination, this led to my pilot study on neurofascins in multiple sclerosis. First few cases, I have sent anti-neurofascin 155, which came positive in some, which came negative in some. Then, with the availability of a panel against neurofascins 140, 186, and 155, we started doing neurofascins in our MS patients from our MS registry. And we excluded peripheral nerve demyelination initially by nerve conduction studies, which we done few of the patients, but after that, because they were normal and they were clinically MS, we did into further nerve conductions, but the initial patients whom we did the nerve conductions were normal. So we thought of checking 155 followed by other antibodies, and these are the few cases. This is that already these are patients in our MS registry, which we run from 2016 onwards. This is a lady in our MS registry who is 33, coming with left hand numbness and weakness. She had partial recovery with Trisabri. She's on injection rituximab currently and fairly doing well. And this is MRI showing demyelinating plus, juxtacortical, periventricular, and then the spinal, and you can see the spinal lesions, more central and little bulbous. And you can see the neurofascin 155 is positive in this patient. And this another 24-year-old lady, RRMS from 2019, had burning sensation of the ear lobes. 2022 had imbalance. She's on rituximab, and this MRI showing periventricular small plaques, juxtacortical lesion. And you can see the corpus callosal involvement and the spinal lesions. And then she was positive to neurofascin 927. And this is a summary of the neurofascin testing in our patients. We have done for almost 71 patients when we did this analysis. NF155 was positive in 4.2% tree, while NF140 was the commonest, which was seen in around 26, around 36.6%. 186 came next, around 18.3. Combined 140, 140, 86 together, another 14, 19.7. And then, if you see here, it is covered by my video here, but around 80% of them were positive for any one of these antibodies, and around 20% were negative. And so the least observed combination was a 140 and 155. And we did comparison of the groups with 155, 186, 140, and combined. And we could not find any difference with respect to onset age, disease duration, DMT use, EDSS, subtype of MS. Only one thing was NF140 was more common in patients with long-standing disease, and that's the only thing. And then we published this article in our Neurology India, and this is available now as an original article. As a brief report, we published that a pilot exploratory study showing neurofascin positivity in patients with multiple sclerosis. And we concluded that at least one of the neurofascin antibodies present in a significant number of MS patients, around 80%, and 140 and 186 were found to be more common. And we should do further immunological and molecular investigation, and we need studies from across the world to confirm the findings of this study. And we used an ELISA technique with a human antigen to check the neurofascin. We're trying to make a cell-based assay and other assays, but studies have shown that both cell-based assays and the cell-based assays and ELISAs and various other techniques are comparable with respect to the results. But anyway, we are trying to make a live cell-based assay, and we will further work on neurofissions and other immunological disorders. We had neurofission-related pure autonomic dysfunction. We have neurofission-related recurrent cranial palsy because neurofission spectrum is wide, and whether the neurofission are you're a terminal pathway or an initiating antibody, we're not sure at this time, and then we will see further research into this, and then we may be able to have more ideas on that. We also did a comparison and the antibodies with respect to this disease duration in various subtypes, and we found that what came positive was in progressive MS group, there was a high titer of neurofishin 140, and that's what came significant in further studies. And this we published, presented in Paktrims, recently conducted Paktrims in Barcelona, Spain. We presented on the significance of high titers in patients with progressive MS. And you know that neurofissions are cell adhesion molecules. They are critical for formation and maintenance of nodes of Ranvier. And this is Professor Van Bennett, who was working on neurofission and published a maximum on the basic sign work on encarins and neurofissions. And we know that there are three important neurofissions in adult, and one is 140, which is more of embryonal, and 186 is the adult, which is found in the axons, and then 155 is the glial form. It's found in oligodendrocytes in the brain and Schwann cells. So most of the case of combined central and peripheral demyelination happens with NF155, but here, when there is more of a pure CNS involvement, and also in cases of pure autonomic neuropathy, it was more of neurofission 140 and 186. And most of the Western studies have done on 155, and they have not done a full panel using neurofission. And that is one of the strengths of our paper. And you know, this is a neuromuscular junction. You can see the NF 150, 186 coming from the axon, and it connects the ankyrin. It connects to the gliomedin in the Schwann cell microvilli. And you can see a lot of sodium channels are clustered here. So this keeps the molecular integrity and functional integrity by keeping enough sodium channels for saltate reconduction. While NF155 is paranodal, it arises from the Schwann cells and connects to the axon through conductin 1 and Casper 1, and again forming a molecular boundary which separates the potassium channels from the sodium channels. And then NF140, though it's embryonal, it's usually absent from adult, but when there is any problem, it gets re-expressed. And this re-expression is identified in the white matter lesions of postmortem brain tissue from human subjects with MS. So maybe the antibodies are coming, the anti-neurofishin antibodies are coming, knocking out 186, then 140 gets expressed, and then it is getting knocked off, and more that's why it's found in more longer the disease. Maybe it's re-expressed, and then you get this NF140 antibodies. And neurofishin 140 is an embryonal neurofishin isoform that promotes assembly of node of Ranvier during development. But it's an interesting thing that the same gene codes for the three neurofissions. So it's an unusual example of a functionally cooperative cell type specific alternative splicing of a single gene in the cell biology, because all these neurofissions can act as complementary to each other. So 186 goes 140, gets expressed, and it can do the function of 186. So they works complementary and produced by the same gene by alternative splicing. And now the question is, are neurofissions truly pathogenic, or it is a bystander phenomena, and do we have evidence? And we have one paper by Mathew et al. In Journal of Experimental Medicine that neurofishin as a novel target for autoantibody-mediated axonal injury. And this is a paper, a wonderful paper, where they describe neurofissions and how they become pathogenic, especially with respect to MS. And they found that there was a high titer of neurofishin antibodies in a subgroup of MS patients. And when they injected this neurofishin into the rats, they found that substantial increase in inflammatory activity. And when they injected anti-neurofisins in the rat hippocampal slices, that led to axon conduction block. And then there are studies from patients with combined central and peripheral demyelination, where they've taken the sera of patients with anti-neurofusion antibody 155 positive and injected in the mice brain, and there was an increase in the inflammatory activity in the brains of the mice where neurofusions were injected. And Stichital has done studies in MS patients on neurofusions, but they have all done studies on 155, and they found that around 4.8% of all primary progressive MS had anti-neurofusion antibody positivity when compared to RRMS and healthy control. But all these studies have used 155 antibodies. They have not tested 140 and 186. And they also found that those with anti-NF reactivity experienced an above average progression of disability compared with MS natural history controls, but we have not observed that in our cohort. And another important good news is that, anti-neurofusion antibody, specific to the antibody synthesis, was not detected in MS patients in the CSF compartment. So that is good. It is more of serum, like our NMO and MOG. So we don't need to do the lumbar puncture to find anti-neurofusion antibodies. And various studies have shown that anti-neurofusion antibodies can cause conduction block, paranodal dissection, axoglial detachment, so resulting in a functional block of conduction, and saltatory conduction is blocked and you get weakness, and very classical of MS and other diseases. You may get paranodal demyelination, impaired myelination. It is a non-macrophage mediated inflammation and less of complement, and that's why the disease smolders and you get a good response. And even the disease advances for many months and years, you still get good response because there is not much complement mediated damage. And then, unlike the NMO and other disorders, and then finally impaired saltatory conduction and axonal disruption. So multiple ways how the neurofusions cause this problem. So are neurofusions truly pathogenic? Are they disease modifying? Or is the terminal pathway of damage? Or is an incidental finding? We are not sure at this moment, but these findings looks good. And you know that the B-cell therapy does well in MS, and that one of the reasons maybe this neurofusion antibodies may be pathogenic and they're very sensitive to rituximab, especially the IgG4 subtype, and that may be the reason for a good response in MS. So is this a true Asian and Indian MS? Maybe Western population different, we don't know. Is MS a neurofusion mediated isolated central demyelination possible? Further studies across centers have to come. Are there further subtypes of MS based on neurofusion antibodies? We need more studies. And are long-lived plasma cells producing these antibodies is the cause for MS being a long-term or a lifetime disease? So whether we should plan anti-plasma cell strategies against long-lived is a research question which needs to be addressed by future studies. So a complete workup of a patient with MS or a dermal disease, we like to include this antibody of neurofusion also, and especially a panel with 150, 186, 140, both for research and further studies, along with the MOG and coporin antibodies, and maybe GFAP and other antibodies. But this also is important, and especially not in MS, but of central demyelination, isolated peripheral demyelination, recurrent cranial palsy, and patients with autonomic dysfunction. It may be important to test these antibodies. And the implications are, if neurofusion is positive, we know that rituximab becomes an ideal choice than other DMTs, and that maybe these are all not conclusive statements or open statements, which needs further research and critical reviews and experiences from clinicians all over the world. And with this, I will conclude my talk, and I've shared my findings. One of the neurologists from Kenya, Professor Bundy, and then we have Professor Neil Robertson, and they were interested, and they may replicate and test these neurofusions in their cohort of MS patients, and that may start a new journey. And I once again thank the Paktrims organizing committee for inviting me, especially Professor Mohammad Wase and Naib Ali Khan for inviting me to deliver this talk. It's always a pleasure to be, also delight and a joy to be part of this meeting of Pakistan MS Research Society, and hoping to meet you next time. Sorry, I had to record this session, and reason is that I'm going to Europe to present on an important topic, toothpaste and headaches, which is one of my important research of neurotoxicology. And thank you so much. Thank you so much. God bless you.